Welcome back to the our continuing podcast series on the nursing process. We already talked about the overview of the nursing process. We talked about assessment. We talked about diagnosis. And of course, now planning is next up on our trip here. So don't forget our nice little mnemonic. We talked about assessment, diagnosis, and here we are at the third step, planning. And talking about planning, you can never go wrong about planning like a cat. So the only thing on their mind is that they need to plan is where in the world are they going to fall asleep next and curl up in a ball on a nice comfy blanket and go to sleep. I don't think I could ever handle being a cat. It looks like it's such a stressful life. But anyway, moving on to outcomes and interventions and planning. So what we have here is we have two different things that are under the same umbrella. So we have outcome planning and we have intervention planning, and they're similar, but they're very different at the same time. So outcome is what is to be achieved. So that gives us the what after our nursing statement. Now we have to figure out what we have to do. Our nursing diagnosis, our nursing statement shows us the problem that we have to address, but it doesn't tell us really anything about how we need to go about doing it or what we want to have happen. And that's what our outcome statement is doing. Conversely, our intervention plan is going to tell us how that will be achieved. So going back to the outcomes, these stem from our nursing diagnosis, from the problem part of our nursing diagnosis. And then we have two different types. We have short-term versus long-term. We kind of talked about it already. We'll talk about it a little more about what that really means, what it means to be a short-term goal versus a long-term goal. And these are always going to be they're always going to be written as patient will. This is what the patient is going to do in order to reverse or to stagnate a particular problem that they are dealing with. Interventions, on the other hand, are a little bit different. They're a little bit more specific. So interventions, again, we're talking about the how it will be achieved. These stem from the etiology, and they're focused by the outcome statement. But they are the etiology, because remember, in our nursing diagnosis and our actual statement, don't forget our generic problem related to etiology as evidenced by our signs and our symptoms. So our outcome here is going to be focused from our problem. Our intervention is going to be from our etiology. And the big question is, why? Why is that? Remember, our etiology is what's causing the problem. What process or processes is causing this problem to happen? So in order to reverse it, the problem, we need to address the etiologies, and that's what the interventions are going to do. And these can be several different types. They can be direct versus indirect. They can be independent versus dependent. And these are always phrased as nurses will, because this is what we're actually doing for our patient to make sure that they can achieve this outcome that we have set. So the patient is responsible for reaching this outcome, or for reaching this goal. We are responsible for helping the patient get there. So I like this. You're going to see this again before I pull this up in lecture and showed it to you here, because I really, really like it, because it gives a really good idea of where we are pulling this information from, and also it gives us an idea of how vague or how specific these statements need to be or are going to be. So let's look at the problem first. So remember, problem related to, and then we have evidence by. Our signs and symptoms are just supporting the other two parts of our nursing diagnosis. So our problem is constipation. So our standardized care, which is going to be our goal, we want to administer a stool softener or laxative at bedtime, encourage increased fluids, so patient will increase fluids, so on and so forth. How are we going to do that, or what is really the core of what's going on? It is our etiology is related to we're having constipation issues because we're having issues with immobility because of a decreased GI motility because of narcotic medications. So now what we can do is make individualized care plan or interventions, and now all of these things are going to address the problem of decreased GI motility. So the next question is, are these direct or are these indirect? So this first one here, this would be actually a direct intervention, and this one actually is an indirect measure, because we actually have to control pain first before we can decrease the amount of narcotics that we're giving, thereby increasing bowel motility. Do you see that? So we really made a couple extra steps. We're not going directly to the problem like a high fiber diet would do. We actually have to take a couple of steps. We're kind of going a little bit of a roundabout direction here with this type of intervention. But we'll talk a little bit more about that later in much more detail. Let's continue. Let's look back. Let's go back to the planning outcomes phase, the first part of the planning phase. So here is our knowledge map. Again, this is taken from Wilkinson and Treese, and this is more of a circle with a little crescent moon at the bottom. It sort of looks like it's starting to form a Venn diagram, but not really. So anyway, so what we're interested in developing are something called comprehensive care plans, which means that they address everything. They include all of our different components, and these can be completely as variable as everything else in medicine is. So standardized plans, individualized plans, discharge, teaching plans, computerized plans, these are all different types of comprehensive plans. Other forms of planning are going to be formal, informal, initial, ongoing, and discharge. So these are the type of plans that we're going to develop. So again, remember, discharge planning always starts upon admission. Once we first assess our patient, we need to figure out how to send them back home. How do we get them back to baseline? So we always want to include some way of how are we going to get them back to discharge, but there are also specific discharge plans out there. But all of these involve goal and outcome statements. And we can use standardized language. This comes out of you can use your NANDA 1 diagnoses, NOC outcomes, CCC system, Omaha system. These are all different types of standardized nursing care plans that are in use. Typically, though, in this area, the NANDA diagnoses are what's used most frequently. So also with your comprehensive care plans, these include a bunch of different things. So these are going to be dictated by your facility policies and protocols. What you can, what you cannot do, what they are set up to do, what they are allowed to do legally, that kind of thing. Protocols, same thing. Unit standards of care. So depending on what unit you are, you may have different standards that you follow for different situations, like pain analgesia, skin care, oral hygiene, maybe different things of that nature. Critical pathways and integrated plans, these are all parts of automatic charting, trying to do more. These are different evidence-based methods to incorporate into create patient care plans. So an overview again, so we have initial versus ongoing goal setting. So this initial, of course, is when we first meet our patient. You can see this in the long-term care setting. You can see this in the acute care setting. You can see this in pretty much any setting that you're going to come in contact with patients. This is someone who's brand new to you, someone who you've never seen before, or at least this is an initial encounter of an individual. Ongoing care planning, this is when you're coming back and or even in the same shift, you are your patient's going through and you're addressing different things on an original care plan, and you're going through and you're reassessing. This is you're reevaluating, you're revamping that care plan. Long-term care, our overarching theme or goal is going to maintain current level of function as much as independent as possible. Acute care, it's all about discharge planning. Discharge planning happens at admission because that's our goal. Our goal in acute care is to return the patient to their baseline that was prior to change in health status. So, and this is also going to include any special discharge or teaching needs that your patient will have to have in order to be discharged home, to make sure like they have the correct number of services lined up, or if they need to have follow-up appointments, things of that nature. And a lot of times I look at clinical paperwork with the acute care side, and sometimes I'll see, even if it's, especially if it's a really simple patient, oh, no discharge needs. That's a lie. Everybody needs something. They need some type of service. So you need to be creative and you need to come up with that, and you need to be able to tell me with any patient that you have, what are their discharge needs? They need something. Within this goal setting care section of the care plan, information contained, basic needs and ADLs, medication, multidisciplinary treatment, nursing diagnosis and collaborative problem, and then also the short-term goals and long-term goals. A lot of this stuff is going to be done mostly by the RN. However, you may be called in to do a section of this or something as well, and then the RN will review it. So let's talk real quick about short-term and long-term goals. So this is going to be a real big important section here. 99.9998% of your nursing care plans that you're going to be doing, at least within this program, are all going to be short-term goals. Can they be achieved in a few hours or a few days? Because we're dealing with patients on the inpatient side of the hospital, and they're only there 2, maybe 3 days if they're lucky, and then they're discharged home or discharged to a rehab facility, something like that. So situations where you would use short-term goals: acute care, day surgery, clinics focused on immediate needs, students, eval progress towards long-term goals. So you may maybe incorporate a short-term goal with primary care if you're in a provider office, especially if they have a follow-up in like a week or 2 weeks or a month or something like that. So you could get maybe like one short-term goal if they're coming in like in a couple days for another follow-up visit. Patient will be able to like demonstrate be giving their own insulin, or patient will be able to demonstrate or be able to show you the correct way of doing peritoneal dialysis, something like that. I don't know. But other examples, though, describes pain is less than 3 on a 1 to 10 scale within 30 minutes after raising analgesic. Limit food intake to 1,500 calories per day. These are all different types of short-term goals. So this is only going to last really a day or two, maybe even a few hours, especially like the patient will be NPO until gag reflex is present or something like that. For post-op patients, something like that would be short-term goals. Long-term goals, again, these are going to be expected changes that occur over a week, month, or more. This is going to be where you run into it with long-term care, home health care, rehab centers, chronic illnesses, things that are going to take a long time to resolve, if ever. So the process of developing a goal or outcome statement for your care plan, first of all, you want to make a working problem list. We already did this as part of our assessment, our data collection and analysis. We want to decide what problems can be managed with critical pathways or standard protocols. So basically what that's saying is what problems are already addressed by things that we already have in place at our facility. Once we strike those off our list, now we can individualize the standardized care plan as needed, document orders in appropriate areas, develop individualized. Then we can develop individualized care plans not addressed by standardized documents. If we already have something that fits, that's already set, that's a standard document, don't reinvent the wheel. You have other things to do. Use them, make them fit your patient, but use the resources that you have available to you. And then for those care plans or those problems that are not addressed by standardized stuff, then you need to sit down and then you need to formulate your own care plan. There's a lot of information shuffling. I really like the analogy of how a teenager does laundry, the pile method. You pick up a pile up, you move it, you set it down. You pick it up again, you move it, you set it down. And whatever's left behind, you don't worry about. It's already taken care of, at least in your mind, until you go back and you get yelled at by your roommate or your significant other or whomever that you're leaving a mess behind you. Moving on. So this is an example here. So comparison between diagnoses and goals. This is kind of what we're looking at. So go back to our nursing statement, our nursing diagnosis, the problem aspect. So again, remember our problem is being addressed by our goals and outcomes, and then our etiology is being addressed by our interventions. So note here, so problem differences here between the problem of the nursing diagnosis and our expected outcome. So problem response, opposite of problem response. We want to reverse it. Present health status, what do we want them at? What's our desired health status? Response that you hope to change, response that you hope to achieve. So we're kind of flipping these in reverse. That's all the thing that we're doing. So we're taking the inverse of what our problem is, and that's what we're making our goal or our expected outcome to be. So for example, ineffective airway clearance. So our what's the opposite of our problem response? We want our lungs clear to auscultation. So related to cough secondary to incision pain, that's going to actually be a response that we hope to achieve, a productive cough. So components of our outcome or our goal statement, the must-haves, we must have subject, a subject, which is going to be our patient. So we're always going to start off with patient will. We need an action verb. They need to be doing something. They're accomplishing something. So we need an action verb to describe what they will be doing. We need performance criteria, target time, and special considerations. So all of these can be summarized and described by the SMART objectives, or writing a SMART objective or SMART outcome. So we want them to be specific, we want them to be measurable, we need them to be attainable, we need them to be realistic and timely. So again, specific. So we need to be very precise. We need to spell out, concisely though, spell out what we want our patient to accomplish. They need to be measurable. We need to be able to validate a patient response and say that whether that response is adequate or not. And the only way that we do that is if we include performance criteria. They need to be attainable. Can our patient actually do this? Is this within the realm of possibilities for our patient? I'm not going to send an 80-year-old out to do calisthenics who just broke her hip. Are they realistic? Again, kind of going along with attainable. But what is the reality of the situation? Do we have the supplies at hand to be able to actually do this? And we need time and timeliness. We need to specify a time frame in which this will be done. Again, think back to our long-term versus short-term goals. Do they need to be done in hours, a few days, weeks, months, etc.? If we don't specify a time limit, they're going to be doing this until the cows come home, because we have not said when they need to have accomplished this by. I can't just pull something out of the air and say, oh yeah, well, we'll make it this. No, we need to specifically address this within our outcome statement. So here are some action verbs that you can use to put into your statement. So apply, choose, demonstrate, eat, list, measure, prepare, transfer, select. These are all good verbs to use to describe different actions that you want your patient to do. And if you want to pause the slide here and write them down, you're more than welcome to do that. So let's look at again here, deriving goals and interventions from nursing diagnoses. So we have a problem here, ineffective airway clearance. So goals and expected outcomes. So lungs clear to auscultation, coughs productively, respirations 12 to 20 per minute, no palarocyanosis, no dyspnea or shortness of breath. So that's our goal and expected outcome. Patient will. Nursing activities. So then the nurse will teach deep breathing and coughing, auscultate lungs, Q4 hours, assess respiratory rate, breathing, and skin color. So let's take a look at this though. Let's go for, so this is general. This is using our problem here. So now we have a general outline of what we want to do, or what we can do for this patient. Now let's take a look at more specific things that we can do. And by doing that, and in order to do that, we're going to look at the etiology. So ineffective cough secondary to incisional pain. So that's the problem. That's why we have ineffective airway clearance, is because every time that they try and cough and do clear their airway, they're in pain. So now that we have a specific idea of what's going on, a specific cause to the problem, now we can develop more specific goals and interventions. So cough forcefully, effectively, rate pain is less than 3 on a 1 to 10 scale, and split incision while coughing. So patient will cough forcefully and effectively, rate pain as less than 3 on a 1 to 10 scale, split incision while coughing. And that will happen by nurse will teach to split incision while coughing. Nurse will have the patient churn, cough, and deep breathe hourly. Nurse will medicate for pain 30 minutes before the churn, cough, and deep breathe hourly. So to evaluate the statements, the goal outcomes that we've written, there's a few questions that we need to ask ourselves. So first of all, is there at least one goal that when met will demonstrate patient problem resolution? Do the predicted outcomes completely address the nursing diagnoses? You cannot leave one chunk of your nursing diagnosis unaddressed, because that is something that a problem that you have identified. You need to fix it. Is the outcome appropriate for nursing diagnosis? Again, these kind of go back, and they kind of go with each other. Does it address the nursing diagnosis? Is it appropriate for the diagnosis? So are you trying to stick a urinary measure, a urinary, like a bladder training program with a nursing diagnosis that has to do with mobility? They really don't go together. The urinary bladder program does not address issues dealing with mobility. Is each outcome derived from one nursing, only one, it should be only one nursing diagnosis. So describe one patient response. And this is actually something that a lot of people have trouble with, is to be able to have one separate statement for each, because we all want to condense things and make things a little bit more simpler, or so we think. But in this case, that's not really a good idea. So incorrect. So we have a diagnosis of diarrhea. Patient will not have no diarrhea in the next 12 hours, and skin will be intact and without redness in the peri area. So what we have here, so we have no diarrhea in the next 12 hours, skin will be intact, and we actually have a third one here, without redness in the peri area. So we actually have three different outcomes in one statement. So what we've done here is the person here who's wrote these, so they went, okay, say, aha, we need to make a couple more of these. So they did. So correct, diagnosis of diarrhea, will have no diarrhea in the next 12 hours. Good. One outcome for one statement. However, they kind of got lazy and slacked here on the second one. So we have diagnosis of impaired skin integrity. Skin will remain intact and without redness in the peri area. Notice the asterisk. This is more correct. However, but we still have two responses in one statement. So we actually need to make a third statement, or we need to sit down and really critically think to ourselves, do we really need a response regarding redness in the peri area when we have something saying that skin will remain intact? We're really basically saying the same thing, aren't we? When we say skin will remain intact without redness in peri area. Well, if the skin's intact, isn't that the main point? We're trying to prevent a pressure ulcer from forming. So moving on. So does each outcome describe only one patient response or behavior? So go back and look at those examples that we just talked about. Outcome stated as a patient behavior and not nurse activity. This is really important because people get this mixed up a lot of times. So in the outcome statement, this is what the patient will do. Okay, patient will do this as an outcome. They will accomplish this. When we get to interventions, now again, it's the nurse. The nurse will do this because we're responsible for giving the patient the most optimal chance of addressing that problem. So incorrect, prevent skin irritation. That's a nurse activity. Preventing skin irritation, that's a nurse activity. Correct, though, skin will not show signs of irritation. Whose skin? The patient. The patient's skin will not show signs of irritation. So note that difference there. It seems very minute. It seems like very much splitting hairs, but in the long run, it really does matter how you phrase this. And then are there outcomes stated in positive terms? What intends to occur, not necessarily what should occur. We all know that. We know what should occur, but you need to phrase it as, this is what we intend to. Because what if you don't meet it? Okay. Also, we need to make sure that we write our outcomes in the SMART format, the specific, measurable, achievable, reasonable, timeliness format. Did it include all the necessary parts? Do we have a subject? Do we have an action verb? Did we address all of the SMART objectives? Consider available resources. Don't make an outcome that you don't have the resources to address. Know your facility, know your unit, know what you can do, what you cannot do. Does the outcome conflict with other treatment plans? This is kind of important because you don't want to be doubling the work. You don't want to be double charting this when it's already addressed somewhere else. If it's already addressed somewhere else, leave it be. Find something else that is not addressed, that's within your scope of practice that you can do. Does patient, family, or community value the outcome? And does the goal conflict with any religious or cultural values? Again, this is important to nursing because this is holistic care. That's what nursing is all about, holistic. So let me give you an example here. So expected outcomes for various problem types. So what I like about this is that it really breaks out. So we have different types of issues going on. So let's look at the actual nursing diagnosis here. Let me draw a line here. So we have an expected outcome. Patient will have normal form bowel movement within 24 hours after receiving stool softener. So what are we exactly looking at here? So examples of diagnoses. So constipation related to inadequate dietary fiber and fluids. So explanation of diagnosis. So you can say summary of the diagnosis. What are we trying to accomplish here? So symptoms of constipation present, no bowel movement. Interventions. So resolution or reduction of the problem or prevention of complications. So go back again to Table 5.3 a few slides ago. That's where we are getting this resolution or reduction of problem, prevention of complications. That's what we are intending to do. That's what we're trying to set out to accomplish. How will we do this? By saying that the patient will have normal form bowel movements within 24 hours after receiving a stool softener. Moving on, planning intervention. So this is the how. This is how we are going to go about doing this. So here's again is our concept map for interventions. Notice one thing here, that before with all of the other ones we had this really nice symmetrical movement or linear movement. With this one with interventions, they're going all over the place. Because remember, with the interventions, developing these interventions, we are pulling information, we're pulling theoretical information in that we know about the disease process for something, for a certain problem, the pathophysiology behind a certain problem, the anatomy behind a certain problem. We're pulling in the nursing theory that we know regarding Maslow's hierarchy of needs, the needs in one of our patient. We're also pulling in our own experience as well. Go back to our critical thinking lecture and recall the prism of how we look through and what we combine to solve a problem for our patient. This is where it all comes into play here when we're planning these interventions for the outcome or goal that we have developed for our patient. So again, we have this one slide that I showed you at the very beginning. Again, this kind of shows us where things are coming from. So our etiology is where we're getting our specific interventions to try and reverse or address what's causing the problem to the patient to begin with. So again, the interventions here, they're also called nursing orders. These interventions and nursing orders are called interchangeably. These are the instructions to the nurses. So again, this is where we have nurses will. And again, because this is what reflects what needs to be done to help the patient achieve a specified goal or outcome. So let's take a look at it here. So we have several different intervention types. Again, we're going to focus on the actual nursing diagnosis. So observation, prevention, or treatment. So those are going to be our options. What are we going to do to try and intervene? So observation to detect change in status. So we're going to continue to assess and evaluate. Prevention, trying to keep the problem from becoming worse, or we're actually going to treat it, relieve symptoms, and resolve the etiologies or the contributing factors to this problem. So that's our three big things that we want to look at when we're writing these nursing orders, these interventions. Those are the three main goals that we're trying to accomplish. So the components, we need the date that we're writing them, so that we know when they were started, when they were initiated. The subject is always going to be nurse. The nurse will. Then we need another action verb, very similar to when we had our outcome statement, because this is something we are doing. We're not just sitting around playing cards. We're actually doing something for our patient. So assist, assess, auscultate, bathe, change, demonstrate, explain, give, teach, turn. These are all different examples of action verbs that we can use to demonstrate what we need to do for our patient. Times and limits. Now, this isn't going to be as specific. Maybe it will be, but in general, you don't have to put really specific parameters like what you do for your outcome statements. When, how often, how long the activity is done, and then you need to sign it. So let's go back again to the times and limits. We practiced this a little bit in class. The Mr. Jones care plan is up on Play-Doh. That's the kind of thing that we need for our times and limits. We still need to have something like that, because otherwise we're just going to be doing it again until the cows come home. We don't know when to stop. We don't know what we were doing in case we have to change our intervention. It isn't working. We can either increase it or decrease it. So we need to actually have some type of limits or some type of parameters in place to really to have enough information to work with it. So if we said, so okay, have our patient use the insanity spirometer. Well, fantastic. That's great. But that doesn't really tell me much anything of how I'm actually going to go about and do that. So then we have an order, insanity spirometer, nurse will instruct patient to use insanity spirometer 5 times per hour, period. Oh. Okay. Then our goal is that they will have increased inspiration in 24 hours. So, okay, we're going to reevaluate in 24 hours, so they need to be doing this for the next 24 hours. That's the kind of thing that you need to be thinking of as you write these interventions. So again, here's some flow from the desired outcome. So again, we have our desired outcome. We'll have bowel movement within 12 hours after receiving stool softener and laxative. So strategies. So our goal, again, we have our direction sent from our goal. Now we look at our etiology. How are we going to accomplish this, or what do we need to really try and reverse or address? So administer prescribed stool softener or laxative at bedtime today. Then instruct and encourage high fiber diet, encourage increased fluids. Again, these are all direct interventions. One thing here, look at D, look at E, look at F. These are all indirect contributions to the goal. So we're addressing them. They will address the goal, the outcome, but not directly. We're actually kind of fixing one thing to try and address and fix another thing. But they still focus in with the intent of getting this patient to have a bowel movement. So these things are multifaceted. That's because patient care is multifaceted. Patient care is very complex. And what separates us licensed individuals from CNAs is we have the education, we have the theory that we can use to apply to these complex situations. So again, I like this one because it shows us we can be a little bit more specific. So standardized interventions encourage increased fluid intake. This might be something that may pop up in your EHR as you're going through an admission process or something like that. Well, that's nice, but let's individualize it a little bit. So, like in the other column, remind patients to drink a glass of water every hour. Also, keep ice and tea available at the bedside. Wow, that's really helpful. That tells me exactly how we're going to go about to increase fluid intake for our patient. We've developed a complete strategy, comprehensive strategy for our patient. And there's other ones: instruct and encourage a high fiber diet. Okay, so that's vague. Okay, it tells us what we need to do. Give us a little bit more information how we're going to do that. Oh, okay, assist with menu choices to obtain more fiber. Aha, Sherlock. Encourage family to bring salads and fruit from home for snacks. Oh, well, that's great integrative care. That's great holistic care. So for critical reflections, in order to evaluate our statements, we have to, again, go back and look at them critically and really evaluate and look and see, are they complete? Do they address the etiology? If we can't address the etiology, do the orders focus on symptoms of the problem? Are we doing this from a holistic approach to our patient? Is each order technically complete? Do they contain the necessary items, the required bits of data? Are they clear, specific, and precise? Are they individualized? Are they concise? We don't need 5 pages for one intervention. 5 words, spectacular. And what's our priority? What's our highest priority? What's our lowest priority? Again, we're just trying to go through and continue using our priority setting frameworks. You'll continue to use these in every single aspect of your care delivery. And that's it. I hope that this has been informal for you guys, informational for you guys. Please let me know your thoughts and reactions to the podcast by following the evaluation link underneath of the link for this podcast. And we will talk about more later. Thank you very much.